right, once again, I would like to welcome everybody to our Cleared for MDM Takeoff Ascending Through Problem Levels, Part 1 of 2. If you have been attending Ashley's and my webinar in the recent months, we have been tackling some topics related to evaluation and management in a two-part series. So today is a continuation of that. So in April, Ashley and I did kick off a level of service series, and we've been breaking down the elements of how to choose your level of service in the last couple of months. So in April, we did a two-part session on time, and in May, we began breaking down medical decision-making, or MDM. And we started in the end of May with an overview of medical decision-making, and we did announce we're breaking that down further, and today we are going to be focused on problem. As I said, this is the first in a two-part series. So today is going to be focused mainly on building your knowledge and helping you gain a better understanding of problem. Tomorrow, Ashley will be conducting the second part in our two-part series, and it's an interactive session. It will be focused on denials and rejections, along with an opportunity to apply your knowledge gained today. So as I said, today we're going to be hopefully providing you with a better understanding of the problem element when you are using medical decision-making, or MDM, to select the appropriate level of service. Now, to do that, we're going to be focusing on the problem element. So we're going to give an overview of when you're using MDM, what that problem element looks like, and how to select the appropriate level of problem or make that determination. And we're going to break down the levels related to problems addressed, and we're going to talk about what problem addressed actually means. And then we also have some examples. So we're going to walk through some examples of some documentation to show you how that information is documented. We get a lot of questions about documentation, so hopefully you'll find those helpful today. Because our session is part of a bigger educational series, and I do not know if everybody who's attending today attended any of our earlier sessions, I am going to start with a very high level overview of MDM just to set a baseline for today's session. So first and foremost, the first determinant of coverage on whether or not a service is going to be reimbursable by Medicare is always going to be the medical necessity of that service provided during that encounter to that patient. Medical necessity drives everything that Medicare reimburses. And medical necessity is outlined in a couple of places, the first and foremost being the Social Security Act. And I have included a link to that, but what that act says, and you can go to that link if you'd like to look at it in more detail, but kind of a summary of that, what it says is that a service must be reasonable, medically necessary, and something that is not statutorily excluded. This is all going to be based on your documentation. You'll hear that from us a lot. We talk about documentation. We'll ask, what does the documentation support? And that really is the core of whether or not a service is being seen as medically necessary when it's being reviewed. So what are you doing for that patient, and why does the patient need your service for this encounter? That's really what we're looking for. If it's not documented, when a reviewer looks at it, essentially it didn't happen. They're not going to make assumptions, and we're certainly not asking people to document every second of the encounter and it be a novel, because MDM, your level of service is based on MDM and not the amount of documentation, and that's intended to streamline that process. But it has to be clear, not only to MAC auditors, so we have our nurse auditors, but we also have other auditors that CMS utilizes, for instance, when they're looking at the comprehensive error rate testing or CERT testing. They are all looking at that documentation. So it does need to be clear. When you're choosing your level of service, you do have two options for most services, time or MDM. We're certainly focusing on problem here, so we are focusing on that medical decision-making piece. You do have a choice for most services, as I mentioned, and we get questions about whether or not it's better to choose time or MDM, and it really depends. You need to look at the service that was provided and decide what makes the most sense. You could have a lower level of problem or in an encounter, but it took a lot of time to evaluate, it's possible the time is actually going to allow for a higher level of code. So you really need to, don't leave money on the table. You did that work. We want the providers to be reimbursed for the services and the level of effort that they provided to that patient. And it's not going to be a one size fits all. And it can vary by encounter. We get questions on whether or not we should always use time or always use MDM, or for this patient it's always time, or this patient it's always MDM. It can vary by patient, by encounter. There are exceptions. Critical care services and emergency department services do have some restrictions on how you choose level of service. We're not going to go into detail into these, but I did want to include them, again, in case someone's on the call or in the session that did not attend our previous sessions. So we're looking at for emergency department services, that is medical decision making only, and that means we're looking at problems addressed, the data that was analyzed, and the risk to that patient from the medical decisions that are making. And I did include the codes here. But the reason emergency department is MDM only is because it's going to vary in level and intensity, and there could be multiple encounters with that same patient. The other thing is that those providers are also going to be seeing likely multiple patients simultaneously. It's going to be really hard to track the time. So emergency department is based on that cognitive load, that medical decision making for that patient in that encounter. The other is critical care. This is an exception. This is not something where you will use MDM. Critical care is considered a higher level of medical decision making anyway. And so it is reimbursed based on that, and it is dependent upon the amount of time. So there's a primary code for the first up to 74 minutes, which is the 99291, and then we've included the subsequent code, which is the 292, and that is for each additional 30 minutes. And again, varies by patient, but that critical care piece, it's considered a higher level of code anyway, so MDM is not coming into consideration. You won't have a low level of critical care from a decision-making standpoint. So next, like I've already mentioned, there are elements of MDM. They are problem, which is our focus for today. And for problem, it is about the number of problems addressed and the complexity of those. And we'll break that down a little bit further in a few minutes. You're also looking at data for MDM, and that is going to be the amount and the complexity of the data that was reviewed. It's not automatic based on diagnosis. It depends on the condition, depends on the patient. So what tests were ordered, what results were reviewed, that type of thing. And then the third piece is going to be risk, and this is going to be the risk of complications, morbidity, or mortality from the conditions and the medical decisions that are being made. That's going to come into play even with problem when we get to some of our moderate and higher risk elements of problem, and we'll tie that back in a little bit later. So there are different levels for problem, data, and risk. There are different levels. The problem element levels, you do have 4. Data and risk, sometimes they only have 3, or they may only have 3, and that is because for some of those elements, CPT is combined straightforward and low. But for problem, we do have straightforward, which is minimal. We'll talk about what that means in a minute. We have low, we have moderate, and we have high. Now, the key here when you're selecting your level of service with MDM is you have to meet 2 out of the 3 elements. So you could have a moderate level of problem, but you have low data and low risk. That would still be coded at low. Conversely, you could have a low level of problem, but you could have a moderate level of data and a moderate level of risk. In that scenario, you would code at a moderate level of service because you've met 2 out of 3 elements, so majority rules there. And then just keep in mind, it can be unique to each patient and condition, those comorbidities really do come into play. So with that in mind, we are going to focus on problem. One thing I do want to call out is that today's session is focused on the problem element. We have seen some pre-submitted questions, and we are incorporating those into our session today, either the material or we'll call them out throughout the session. However, we did also get some questions regarding data and risk. We have taken those back, and we will be including those in a future session. But to keep things focused on problems today, we will not be answering those here. And we will be sending out our chat questions. Ashley is going to be answering those questions as they come into the chat. We will be addressing those on problem. We will not be addressing those on data and risk. But again, they're not forgotten. They're going to be incorporated into our future sessions. So starting with problem defined. So a problem is defined as a disease, a condition, an illness. It could be an injury, it could be a symptom or a sign, a finding or a complaint. It is something that is may or may not have a diagnosis at the time of the encounter. So that's really where symptom, maybe the complaint, the sign, that's where those may come into play. Document those, because those symptoms, those complaints really are the problem in those cases, even if you don't have the diagnosis. They are what's prompting the medical decision making in that session. Maybe they're coming in with they're complaining of knee pain. So what are the medical decisions being made? What is the plan of care? Do they need additional diagnostic testing to figure out the source of that? Are they feeling dizzy or lightheaded? That is a symptom, that is a complaint. Might not know the cause of that. There might be, again, a continuation of that. Just because it doesn't have that final diagnosis does not mean that it is not considered a problem. But it does have to be addressed in the encounter. So what is a problem addressed? So the problem addressed means that there was a problem, a symptom, a condition, a complaint that is addressed and managed during the encounter by that provider. So to break that down a little bit, the documentation is going to need to show what conditions were evaluated for that patient, what was treated, were there actual interventions that occurred in that encounter. If they occurred, what problem were they for? That needs to be clearly laid out. And also, what problems were maybe considered? You could have a patient that has multiple problems. They may not have all been treated or evaluated, but they may have been considered. So again, the knee pain. Maybe the patient is coming in for treatment of their checkup for their diabetes, but now they're also complaining of the knee pain. That knee pain may need to be considered for further evaluation. If it's considered, that is counted as a problem addressed because you are going to be documenting the active consideration or management of that. What it is not is a total diagnosis listing. It could be your patient only has one or two diagnoses, but it could be you have a patient who has kind of a laundry list of conditions or a history. It's not just what's included in their history. And that we do get a lot of questions on. So that is going to lead me to our first example. So what we have here is our examples of problems addressed that were included in some of the reviews that we have. Certainly we don't get documentation for every claim that comes in, but these are some that we found that show kind of a really good comparison. So the first one is showing a problem list. Now this is a problem list. This is that laundry list of conditions. They may not all be addressed in this encounter. Some of them go very far back. They may be addressed, they may not be addressed. We don't know. This is telling us what they have. It's letting us know their onset of problems. That doesn't mean that any of that was addressed in the encounter today. On the right-hand side, what you're seeing is an example of documentation. It's showing the assessment and the plan, and it is calling out the um, items that were addressed and what was done for those. This is a really nice example of how to call out the things that we talked about today, the things that we addressed and focused on in this encounter today. Now, this is not a one-size-fits-all. This is not how it has to come in. CMS nor MACs have templates for what this should look like, but this is an example of something that came in on a review and did support the level of service and did support the level of code that that was billed, because it was clearly outlined what problems were addressed in that encounter. And as you can see, it's a shorter list on the right than it is on the left. It's not bad to have the entire problem list of everything that patients ever had in their history. That's not a bad thing. It's just a matter of that in and of itself does not constitute a problem address. Just because they have it, if you're not actively managing it, it is not something that was addressed in that session. So getting back to the elements, I want to start with a straightforward problem. Now, a straightforward problem is something that is, it's a definite, and it has a definite and prescribed course. A cold for most people would be a very good example of that. You have a cold, you need breaths, you need fluids. There's not really any interventions that are necessarily needed for it. If you're an otherwise healthy person, that is going to be a straightforward problem, okay? It's going to have that defined or prescribed course. Could be something that's transient in nature, and then it is also not something that's likely to have a permanent impact. So another example, a patient with hypertension, a cold, they're otherwise relatively healthy, a cold could meet this definition. Now, conversely, this is where it gets different per patient. If you have a patient that has COPD, a cold may be a minor problem, but it may have higher risk, which makes that problem a bigger deal, because that has a little bit more risk. It's problem data and the risk with MDM. You still have to, we're talking about them separately today, but you do have to consider them together, because particularly the data or the risk component can cause that problem to be a little bit more significant. Next, I want to talk about a low level of problem. So the definition is going to be 2 or more self-limited problems. The example I give here is a mild cold and a rash, with the caveat of an otherwise healthy person. It could be they went on a camping trip, it was raining, they got a cold, and they found poison ivy. If they're otherwise healthy, that might not be a big deal. But again, you have to assess that for the patient. What is the level of problem for the patient in front of you? One stable chronic condition. I am going to talk about chronic versus acute here in a couple of slides, but one stable chronic condition. So an example of that would be controlled diabetes. They're meeting their A1C levels, their glucose levels are where they need to be. Could also be somebody with hypertension that is well controlled. An acute uncomplicated illness or injury, it go back to that patient with the cold, but the over-the-counter medication that they're taking, maybe they're taking some NyQuil, it's not helping. So they are coming in for consideration of some steroids or other medications to help alleviate the symptoms. It's acute, it's uncomplicated, still kind of have that defined course, but they need a little bit more help. Not going on its way. Same thing with the patient that went camping and got poison ivy. The itch and the rash, they're not running their course. They're not getting any worse. It's just not going away. It's uncomplicated. It could just be the practitioner is going to make a determination. Maybe they're going to prescribe some type of a cream or an ointment for that. Next would be stable acute illness. So an example here could be a patient with a sinus infection. The practitioner started a treatment plan. They gave them a Z-Pak, and while that sinus infection, it's not going away, it's not, the patient's not quite or excuse me, it's not going away as expected, patient's not responding to that treatment. So it's stable, but we maybe have to make some adjustments. Next one is acute uncomplicated illness or injury requiring a higher level of care. And this can include a decision for hospital inpatient care or observation care. We get this question a lot. In order to count this, where's that decision for that higher level of care being made? We do have instances where a provider's office will send the patient to the ER, but they're not making the decision for the observation care. They could be sending them to the ER, maybe it's after hours. There's a lot of reasons they could be sending them, but who's making that decision that that higher level of care is needed? Okay, an emergency department is a higher level of care, but who's making the decision that that inpatient or that observation care is needed? Typically, it's probably going to be the emergency department doctor or provider. Not always, but again, your documentation has to support what happened. So here I have an example for low problems. Here you're seeing a couple pieces of documentation, and they have some green boxes. Now those green boxes are highlighting the sections that highlight the key points that we're looking at here, and actually things that were looked at on review. So that patient is coming in with a complaint of knee pain and increased urination. So we see that in the history of present illness. They're talking about that. That's that first box there. And then they're also going to give a description of that patient's history. When we get further into this, they're not addressing that additional history, but the information that they did get. The patient is indicating that they twisted their knee a little bit and they're getting around, but it still really kind of hurts. It's not swollen, it's not tender, but it doesn't feel right. So that is going to be the level of problem. What they did address, as I said, they have some chronic conditions. They did not address those. They also didn't really address the increased urination, and I'll get to that in a second. They really only addressed the knee pain in this, so that would count as one acute uncomplicated injury. And what I say here is that they didn't really address the urination. They did indicate that there is a plan to increase the medication. From the rest of the documentation here, that plan was already in place. They're continuing that. But they also said that they have consulted with urology and there is an appointment. So that increased urination is being addressed elsewhere. It's not being addressed in this visit. So those are the things that you're going to have to dissect in that documentation. So as I said, I do want to, before we go any further, talk about acute versus chronic. This is a question that we definitely get often. One of the questions that we did get was asking if we could elaborate on the definition of chronic illness with exacerbation, progression, or side effects of treatment. And I want to level set that here with what we're seeing as acute versus a chronic. So acute is going to be something that's recent, it's short term, maybe they haven't had it very long. It doesn't have any functional impairment. So the example would have been that rash, that cold, that sinus infection. We are expecting a full recovery because it's an acute condition for a patient without any comorbidities that maybe change that for them. Chronic is defined as something, a condition that's going to last, is expected to last 12 months. One thing that we often get asked is they have a condition, but it hasn't lasted the 12 months. It doesn't have to have lasted the 12 months, although if it had lasted at least 12 months, it would be qualified as chronic. But if they're expecting it to last at least 12 months, so for instance, diabetes, hypertension, generally those are something that are commonly classified as chronic, but it's not based on the diagnosis. You could have somebody that maybe has hypertension because they just won the lottery and they're completely excited about it. You know, it's something that it's temporary. Diabetes, it could be a gestational diabetes, and maybe it's not expected to last past the pregnancy, things of that nature. So you really have to look at what else is going on with that patient And with chronic, it's also along with the time frame, we have to look at what are the risks of death, acute exacerbation, which backs to the question about what that exacerbation is, uncontrolled. So if they're diabetic, the blood sugar is spiking and we can't get it under control. The hypertension is up and down and we cannot get that level. So that's exacerbation. It's not at goal. It's not doing what we expect, and we have to make some adjustments. You're generally going to know, oftentimes patients seen for chronic illnesses, there may be exacerbation, but again, it depends on what's going on with that patient. The other part of chronic is a risk of decompensation or functional decline. Okay, so those are things that need to be outlined in that documentation. One quote that we do like to give, and I'm going to show a chronic documentation example here in a minute, but is that when you're looking at the patient's problem, is it acute, is it chronic? It's much more important to know what sort of patient has a disease than what sort of disease a patient has. And that is a quote from Sir William Osler. And it really drives home the point, or I feel it really drives home the point of you've got to look at the patient themselves. Because again, a patient with a cold, one patient, it's not a big deal. For someone with a respiratory issue, that could be life-threatening. So make sure you're not just looking at the conditions, not just the diagnoses that we're being presented with, looking at the patient in their entirety. So here I have some examples, or a couple of examples, of how a provider might document risk versus acute. So the first box that you see, the neoplasm, the green box is around the date. So this was an example of some documentation that came in that didn't call out chronic, didn't call acute, but they called out the onset, and the documentation is showing that this is still something that they're treating or managing. The date can show that 12 months. Okay, it's showing how far back it went. It could be as simple as documenting that. You also see here a couple of examples in the bullets, and this is just their master problem list, although it also says here reviewed problems. So this could also be another example of problems addressed from earlier, because it's talking about what we looked at. We looked further in the documentation to see what was done for each problem. I haven't included all of that here, wanting to break this down a little bit, but they listed out chronic for a couple of conditions. Using the word chronic, while that is not a CMS requirement, it may be something that could be part of a best practice, but somehow we need to understand that this is chronic for the patient. It's not assumed purely by diagnosis. Though in CMS's chronic care management Medicare Learning Network article, they do list some common diagnoses that are generally considered chronic, but it's still, there are other ways to identify that. Now the bottom one is calling out in the history that they were presenting for follow-up on their chronic conditions. Now we don't know which chronic conditions. We're not necessarily going to assume the ones that are listed in their master list, but here they do have the problems that were addressed in the session listed as chronic. And then for space, I did not include the rest of the documentation, but farther down in the documentation where it talks about what happened in the encounter, it did call out what they did, what testing they did for those chronic conditions as far as monitoring and then the adjustments that they had. It just needs to be clear. As you can see, this isn't a whole lot of documentation that is making it clear that these are the chronic conditions. So moving on to a moderate problem, and this is where I wanted to make sure we were clear on chronic versus acute, that question about chronic illness with exacerbation. So this is going to be that condition that's not at goal or it's acutely worsening, okay? Just having diabetes is not necessarily going to mean exacerbation. They could be stable, but if you are managing the patient's diabetes and you have been struggling to get them at the A1Cs, at the glucose levels, you're having to make adjustments. and there are other interventions for maybe another condition that are impacting it, that could be an example of exacerbation. Okay, if they've been at goal, they have chronic diabetes, but they've been at goal for the last 3 years, they're at goal. That's not something that I would consider with exacerbation. That's one or more chronic with exacerbation. You do also have 2 or more stable chronic conditions. So maybe you have a patient that has diabetes and hypertension. They are well controlled, but they are both chronic conditions. They are both being addressed in the encounter. That would be a moderate level of problem. You could have an undiagnosed new problem. So they have something that has, maybe it's a symptom, maybe it's a condition they've noticed, maybe they came in for a cough and now they've got a rash and we don't know where that rash is coming from, and that's progressing, prompting more diagnostic testing. So like I said in the beginning, you don't necessarily have to have a final diagnosis. You could have one undiagnosed new problem, something that hasn't been addressed previously. Next is going to be one acute with systemic symptoms, and this one gets really confusing. I know Ashley and I have both seen questions on this in our sessions, and I think some of the confusion is coming from some of the examples that are in the CPT. They're good examples, and I'm not saying CPT is wrong in any way, but they call out things like fever and dizziness. It's just those symptoms alone do not necessarily bump something up in the problem level. We're looking for that acute problem with systemic symptoms. Examples would include, say, symptoms that are cardiovascular in nature, respiratory in nature, but you also need to consider what is the risk to the patient if those symptoms are left untreated. So, for example, a UTI with a fever. Depending on comorbidities, a UTI with a fever may be very low risk to the patient and may be a low problem. But if you have somebody that has urological issues, that could be something that is a moderate level of problem because there is a higher risk factor of that problem from being untreated. Next is going to be acute complicated injury. So this is something that is going to generally require evaluation of body systems that are not directly part of that injury. So maybe there's a broken bone, but we have to evaluate other symptoms depending on what, maybe it's a broken rib, but we have to evaluate their lung capacity because maybe that rib punctured a lung. We're looking at something that might be a little bit more complicated for that patient. How it's complicated, why it's complicated for that patient, along with everything else, does need to be addressed in the documentation. So here is an example that we had on our reviews. This one is representing a record that came in with 3 stable chronic conditions, and they were all addressed. Here, what you're seeing are my green boxes around the conditions that were addressed in the encounter, and they had all been indicated elsewhere in the documentation, but indicated as the chronic conditions. They were part of some of those previous examples, and they had onset dates, and I know one of them had chronic in front of them. And that documentation is supporting that those 3 are chronic. They were in for a follow-up, and they're stable. They're just checking in, but there's 3 chronic conditions, so it does classify as that. This is actually an example of a review that came in, and the documentation did indeed support the level of service and the code that was billed. Here is another example of some documentation for a moderate problem. Here we're looking at 2 stable chronic conditions that were addressed, and I have them highlighted. There's some other things going on with the patient. The patient had a fall, they were unsteady when they were walking, but those are things that occurred for that patient. They don't necessarily represent a symptom that aggregates the level of service, say, to a high. They're directly related to the chronic conditions that were addressed, particularly with the dizziness and the fall, they believe was due to the dizziness, and it's directly related to the arterial fibrillation. So that's what we're looking for there. Again, it's addressed and we can um, see clearly. This is another example of documentation that did come in and did support the level of service that was billed. Next is a problem level of high. And I've been doing this with the others as well, but you can see I have um, some examples that are in there. But the level of high problem is going to be one or more chronic condition with severe exacerbation. So with severe, uh, you've got a blood sugar that has shot up to 300 and it was otherwise around 100, 110. It shot up significantly. Could be that there's another medication that they're on that is causing um, this drastic rise in their blood sugar. Um, it could also be, another example could be that you have a patient with COPD and wildfire season. I know in where I'm at, we will start getting some smoke from wildfires north of us. And for an otherwise healthy person, maybe it's an annoyance, but it's not going to make it impossible for them to go outside or impossible for them to breathe. But somebody with COPD, it could be severe exacerbation. They may not be able to breathe. It could be life-threatening to them. So those are some examples of that severe exacerbation. It's something that's kind of coming on really quickly, and it is significant exacerbation above and beyond. It could also be one acute chronic that is a threat to life or bodily function. This can be a lot of different things, but it could be someone with a urinary tract infection, and maybe it's going towards sepsis. So they've got to get the diabetes under control so that this doesn't turn into sepsis, so this doesn't cause breathing problems. There's a whole laundry list of things that can happen there. And here I have included an example of some documentation. It is redacted, so I do apologize. We did get it with the black marks on there. Those were not something that we could get out of there from a visual perspective. So we're focusing on the green boxes here. What this documentation was showing is what was done for the patient. So the patient came in, they have a rash on their face. It's something new. And it's indicated here it's not chronic. They're talking about the timeline without reading through that documentation to you, but they haven't had it for the 12 months. It's not they don't want it to last the 12 months. They're not expecting it to. They want to get that under control. But they're also indicating that that rash is worsening and it's not getting better. The thing that's making this a little bit high is because of that worsening rash, but it is on their face and it is starting to encroach on their eye a little bit, and it is increasing the blurriness that they have. And their concern is about the impact to the patient's eye function. And so they have documented this. There are some documented emergency department visits in here, but it is definitely exacerbated. It is high. They're concerned again with that eye function in here. And they are ordering more labs, and they are also reaching out to other areas to consult on this one. And that's all in that documentation. Okay. So with that, I am going to check in with Ashley for any unanswered questions in a minute, but I do want to call out some resources that we have provided for you today. We have provided you a link to the claims processing manual, or chapter 12, where it does talk about level of service. It's not going to necessarily dig into the examples of problem that we did today, so I hope you found those documentation examples, those clinical examples useful, but it is going to talk about CMS's take on that. They do largely align with CPT as far as the levels. They do align, and they do call out CPT as your main resource for that. They do talk about the documentation piece, and again, that documentation has to be there in order to support the code that's built. Also included CMS's Evaluation and Management Services Guide. There's a lot of great information there. And then there is also a medical decision-making FAQ that's out there. TPEs, the Targeted Probe and Educate, there are TPEs happening with Evaluation and Management Services. I'm just going to take a minute. Give me 1 second. I'm going to take you out there. It did include a resource for that so that everyone is aware of what is going on with TPE specific to evaluation and management, not necessarily specifically based solely on problems, but this is something that is for your awareness, that we want you to know that that's happening and know that that's available. Also, our cert. So this is going to be our error rate testing. There are certain codes that are being looked at and certain E&M services that are being looked at as well. We do have a resource out here that does talk about the codes that are being reviewed, and when we see these errors, it all comes down to the documentation not supporting that code. All right, so with that, I am going to check in with Ashley and see if we have any unanswered questions in the chat.
All right, let me do a double check, but I don't believe. Nope, we do not have any unanswered questions in the chat.
Okay, thank you for that. Thank you all for the pre-submitted questions and the questions that Ashley directed in the chat for you today. Now, I know it can be helpful for everyone to see those questions, and what we are going to do today is we are going to take those questions related to problem and the answers. We are going to send that out to all attendees so that everybody will have those. Also, if you did put any questions in the chat that were specific to data or risk, we will be answering those, but we will be incorporating those into a future session. We want to keep this session focused on problem, so I hope you found that helpful. But again, rest assured, we are going to address those questions just in a future session. So we'll start our wrap up. So in a few minutes, you are going to receive an email that is going to thank you for attending. Please do not delete that without reading that. It's a couple of things. One, it contains a survey for you to provide some feedback on how we did today. So that is there for you. But also, if you're attending today for any continuing education credits, we don't offer the continuing education units, but what we do is offer certificates of achievement that can be submitted to your accreditation or your certification body in order to count towards those. So if you don't get this email, one of two things happened. Either you attended by phone and I don't have a systematic way with which to confirm your attendance, or it went to your junk and spam folder, because our WebEx Messenger email, which is from our software for this webinar, is not on your safe sender list. In either event, I'm going to ask Ashley to place a link to our education mailbox in the chat. You can send an email to that, let us know that you attended, but also include the phone number from which you attended. From there, I can confirm your attendance and I can get that certificate out to you. As I mentioned, we would like to encourage you to take a few minutes to complete a survey, again, letting us know what we can do to support you, what we are doing to support you, and also any education topics that you would like to see us address in the future. A couple of ways you can do that. As I said, the email. Ashley has placed a link for that in the chat. You're also going to get a redirect at the end of this session, and it's going to look like that external site image you see on your slide now. It is not malicious. It is not spam. It is not taking you anywhere you do not want to go. or anywhere dangerous. It is simply leaving our webinar software and letting you know it's taking you to CMS's Qualtrics survey software. So again, we appreciate the time that you take to provide us a little bit of feedback. With that, questions. If you have any questions in the next 7 days, you'll also receive some information in the chat. We will be taking additional questions on problem in the next 7 days. Also, if you have questions for data and risk, feel free to submit those, but please know that those are going to be addressed in the future sessions coming up in the coming weeks. And the registration is live for those at this time, so you can check that out on our live events page. But go ahead and send any questions that you have. It is that WPS-GHA education mailbox. Make sure that you're putting something in the subject line that is indicating the title or a part of the title of this session. That just lets our teammates know that they need to get that email to Ashley and myself so that we can get answers for you. So with that, that is going to end our presentation for today. On behalf of myself, Ashley, and the entire provider outreach and education team, I would like to thank you all for taking the time to attend today. We're all super busy, and I know taking an hour out of your day to attend a session can be a bit of a challenge. So again, we thank you for that. I hope you found today's session helpful, and we hope to see you in our future events. Have a great day. You may now disconnect.